anti-adrenergic drugs মানে কি বুঝি আমরা? Basically the drugs that act on the adrenergic receptors, they block it, those are called anti-adrenergic drugs. These are drugs which antagonize the receptor action of adrenaline and related drugs. Now they are competitive antagonists at alpha or beta or both. আমরা জানি adrenergic drugs গুলো basically act করে দু type of receptors on alpha receptor and on beta receptors. So these drugs can either block alpha or beta or both. They differ from adrenergic neuron blocking drugs. How? Now, number one, adrenergic drugs, they act at the receptor level, while the adrenergic neuron blocking drugs, they act on the adrenergic neuronal membrane. They either basically they modulate the release of the catecholamines. The effect of adrenergic nerve stimulation, it is blocked, and less completely, it is blocked more completely. Now, when a patient on the drugs are given are injected adrenaline, the action of adrenaline is blocked with anti-adrenergic drugs, but these are not blocked. And the type of effect blocked by a single drug, either alpha or beta, here both, irrespective of the receptor type. Examples of anti-adrenergic drugs, phentolamine, which block the alpha receptor, and propranolol, which block the beta receptor. And while in case of adrenergic neuron blocking drugs, reserpine, guanethidine and others. Now, this is a classification of the alpha adrenergic blocking drugs. Alpha adrenergic blocking drugs can be of two types, non-equilibrium and equilibrium type. What do we mean by non-equilibrium and equilibrium antagonist or competitive antagonist? মানে কি? Antagonism two type হয় আমরা জানি, competitive and non-competitive. Among the competitive ones, there are two types, equilibrium and non-equilibrium. In equilibrium, basically the blocker, they interact with the receptor. They are of the their structure is similar with the agonist, and they act at the same site. We know. In case of non-equilibrium, the structure is similar, the site is same, but they bound covalently, so that it is not easily displaced from the receptor site. And example of non-equilibrium type, example is phenoxybenzamine, is a non-equilibrium competitive antagonist of alpha receptor. Equilibrium type, it can be non-selective, alpha 1 selective, alpha 2 selective. We know alpha receptors are of two types, alpha 1 and alpha 2. So, non-selective, it can be ergot alkaloids, ergotamine, ergotoxin, hydrogenated ergot alkaloids, dihydroergotamine, dihydroergotoxins. We will discuss details in the serotonin drugs. Then phentolamine is a rapidly acting alpha blocker, chlorpromazine. Among the alpha 1 selective is prazosin, terazosin, doxazosin, alfuzosin, tamsulosin, silodosin. While alpha 2 selective is yohimbine, is basically there is no clinical use for yohimbine till now. Now, general effects of alpha blockers. Now, we all know alpha 1 receptor stimulation that cause basically vasoconstriction. Now, we are blocking the alpha receptor. So, there will be blockade of vasoconstriction action. As a result, there will be vasodilatation. Due to this, there is pooling of blood in the capacitance vessels, venous return and cardiac output are reduced, leading to fall in blood pressure. Now, this can cause postural hypotension event because of venodilatation. There is marked hypotension on standing, dizziness and syncope can occur. So, একটা person on alpha blocker দাঁড়াতে গেলে মাথা ঘুরতে পারে, অজ্ঞান হয়ে পড়ে যেতে পারে. This is because of postural hypotension. Hypovolemia accentuates this action. Now, the alpha blocker abolishes the pressure action of adrenaline, which then produce only fall in BP due to beta 2 mediated vasodilatation. Now, there is a term called vasomotor reversal of Dale. What does it mean? It was shown by Sir Henry Hallett Dale, so that Dale name is there in 1913. What happens when we inject adrenaline? What response we will see? We will see alpha receptor mediated vasoconstriction causing a rise in BP. Again, adrenaline acts through beta 2 receptor also, which causes vasodilatation, and there is slight fall in blood pressure. When before injecting adrenaline, if a person is given alpha blocker, then what will happen? There will be no alpha action, there will be very slight rise in BP because of beta 1 action, but there will be marked fall in BP because of beta 2 action. What does beta 2 cause? Beta 2 are present in the blood vessels causing vasodilatation. So, this is called vasomotor reversal of Dale. That is, instead of showing rise in BP, the adrenaline drug is showing fall in BP. Now, pressure and other actions of selective agonist phenylephrine are suppressed. There is reflex tachycardia. Why? Because of fall in mean arterial pressure and increased release of noradrenaline from cardiac sympathetic neurons. The alpha 2 receptors are present in the presynaptic terminal, and because of alpha 2 receptor blockers, the noradrenaline release is increased, causing tachycardia. Again, due to venodilatation, there is postural hypotension that is causing reflex tachycardia. Nasal stuffiness may be seen because of blockade of alpha receptor in the nasal blood vessels. Meiosis can occur because of blockade of alpha receptor in the iris radial muscles. Intestinal motility is increased, and again hypotension produced alpha blockers can reduce renal blood flow. So what will happen? The GFR will reduce and there will be more sodium and water retention that cause expansion of the blood volume. This is reinforced by the reflex increase in renin release mediated through beta 1 receptor. Alpha 1 receptors, they are present in the prostatic urethra and in the bladder base. And what does they cause? In patients of prostatic hypertrophy, benign hyperplasia of prostate, the tone of the bladder smooth muscles, bladder trigone and prostatic urethra are increased. So urine flow is decreased. So by giving alpha blocker, basically we can decrease the tone of bladder trigone, sphincter and prostate, leading to improvement in the urine flow in a patient of BHP, that is benign hyperplasia of prostate. Again, the contraction of vas deferens and seminal vesicles, they are that result in ejaculation, that is mediated by alpha receptor. By causing alpha blockade, the ejaculation may be impaired, resulting in impotence. So these are some of the side effects. General effects of alpha blockers: no effect on the adrenergic cardiac stimulation, bronchodilation, vasodilatation and most of the metabolic changes which are carried out by beta receptor. Apart from these common effects, most of it manifest as side effects. Many blockers have some additional actions. We will see. Phenoxybenzamine. Phenoxybenzamine, we understood, it's a non-equilibrium type of alpha blocker. Now, why it's non-equilibrium? Because it cyclizes spontaneously in the body, giving rise to a highly reactive metabolite, ethylene iminium, which react with adrenoceptors covalently, causing blocking of the alpha receptors. So it's a non-equilibrium type. It develops gradually over 3 to 4 days. It develops gradually even after IV injection and lasts for 3 to 4 days. Apart from alpha blockade, it also shows anti-serotonergic action. They also block histaminergic and muscarinic receptors, but beta receptors are not blocked. The fall in BP caused by phenoxybenzamine is mainly postural. Why? Because venodilatation is more prominent than the arteriolar dilatation. In recumbent position, the cardiac output and blood flow to many organs is increased, resulting in reduction of pulse rate and increased venous return. Phenoxybenzamine, they cause shift of blood from pulmonary to the systemic circulation because of the relative effect on the pulmonary vascular bed and the systemic bed. They also shift fluid from the extravascular to the vascular compartment. They are lipid soluble, penetrate brain, and on rapid IV injection can produce CNS stimulation and nausea vomiting. Major side effects are postural hypotension, then palpitation, nasal blockade, meiosis and ejaculation. The দুটো side effect বলা হয় postural hypotension, impotence. Phenoxybenzamine is used primarily in pheochromocytoma. Pheochromocytoma টা কি আছে? It's a tumor of the adrenal medullary cells that secrete catecholamines. Now, they are also occasionally used in peripheral vascular disease. Coming to phentolamine, unlike phenoxybenzamine, it's also an alpha blocker. Unlike phenoxybenzamine, it is rapidly acting for short duration. Rapidly acting alpha blocker with shorter duration of action, non-selective, blocks both alpha 1 and alpha 2 receptor. Venodilatation predominates over arteriolar dilatation like that of phenoxybenzamine. Used for diagnosis and intraoperative management of pheochromocytoma. Because of short acting, it's not used for longer period. Only for short duration it is used. So intraoperatively and for diagnosis. They also used to control hypertension in clonidine withdrawal, Chase reaction and others, and also for local infiltration to counteract vasoconstriction caused due to extravasation of noradrenaline during their IV infusion. Prazosin. Now, phenoxybenzamine, phentolamine, they were basically non-selective alpha blocker. They were blocking both alpha 1, alpha 2. Now we are coming to the alpha 1 selective drugs. So is a highly selective, is the first of the highly selective alpha 1 blocker having alpha 1, alpha 2 selectivity ratio 1000:1, and it blocks all type of alpha 1 receptor equally. It blocks sympathetically mediated vasoconstriction and produces fall in BP. But tachycardia is mild unlike the non-selective blockers. Why? Because it is not blocking alpha 2, which causes increase in release of noradrenaline. Acha. They dilate arterioles more than the veins. So arteriolar dilatation is more than the venodilatation. So what the positive effect? There will be lesser postural hypotension, unlike the other drugs. So postural hypotension is less marked, even though, but it can occur in the beginning, that causes dizziness and fainting. That is the first dose effect. Now this can be minimized by starting with a lower dose and at bedtime. ফার্স্ট ডোজ এফেক্টটা কি আছে কি যখনই ড্রাগটা আরম্ভ করব কিছুদিন কিন্তু পোস্চুরাল হাইপোটেনশনটা থাকতে পারে, পেশেন্ট কিন্তু ডিজিনেস সিনকোপাল অ্যাটাক নিয়ে আসতে পারে, কিন্তু উইথ টাইম কিন্তু প্রাইজোসিন বা অ্যালফা 1 সেলেক্টিভ ড্রাগসে এই এফেক্টটা চলে যায়। সো ইট ইজ কল্ড ফার্স্ট ডোজ এফেক্ট। Subsequently, tolerance develops to this side effect due to hemodynamic adjustment. Other alpha blocking side effects like meiosis, nasal stiffness, impotence, they are less marked. Because of milder side effects, prazosin and other alpha 1 drugs, they have largely replaced phenoxybenzamine. They also inhibit phosphodiesterase. Phosphodiesterase ki kore? Basically they degrade cyclic nucleotides. So because of inhibition of phosphodiesterase, cyclic AMP is increased in the smooth muscle, causing vasodilatation. Effective orally, highly plasma protein bound, metabolized in liver, excreted in bile, plasma half-life 2 to 3 hours, and effect of a single dose lasts 6 to 8 hours. Uses antihypertensive, first one, second is Raynaud's disease, and third is benign hyperplasia of prostate. Prazosin blocks alpha 1 receptor in the bladder trigone in the prostatic urethra, thereby improving urine flow and reducing residual urine in bladder. Terazosin. Terazosin is similar to that of prazosin. It is a selective alpha 1 blocker. The difference is, number one, very important, is long acting, which was not in case of prazosin. And number two, higher bioavailability. And in case of prazosin, it was only improving the urine flow in a patient of benign hyperplasia of prostate. Now, it has got additional action, probably apoptosis promoting effect on the prostate. So, what happens in benign hyperplasia of prostate? There is prostatic hypertrophy of the smooth muscle. Now, they are promoting apoptosis of the prostate. As a result, prostatic size is decreased. So, it is also helpful. These are other usefulness in the benign hyperplasia of prostate. This effect is unrelated to the alpha 1 receptor blockade and may retard the progression of prostatic hypertrophy. Doxazosin, similar to that of prazosin, and the same advantage which is given by the terazosin, longer acting apoptosis promoting effect on prostate, used in hypertension and benign hyperplasia of prostate. Alfuzosin is a shorter acting 3 to 5 hours congener of prazosin. They are not useful as antihypertensive. They are only used for symptomatic treatment of benign hyperplasia of prostate. They are not approved as antihypertensive because of shorter duration of action. Metabolism is inhibited by CYP3A4 inhibitors. Tamsulosin. Now, these were non-selective alpha 1 blocker like prazosin and doxazosin, but tamsulosin is alpha 1A selective. In the urethral bed, in the bladder trigone, in the prostate, alpha 1A type predominate. So, what happens? Tamsulosin is a relative uroselective alpha 1A alpha 1D blocker, as effective as terazosin in improving BHP symptoms, but they lack prostatic apoptosis promoting property. They does not cause significant changes in blood pressure and heart rate, and it is not used as antihypertensive. The postural hypotension and the other side effects which we are more with the prazosin, these are not seen with tamsulosin because they are alpha 1 is selective. Postural hypotension is infrequent. Dizziness and retrograde ejaculation are the only significant side effects. One more side effect is floppy iris syndrome. In a patient of cataract surgery on tamsulosin or other alpha 1A blocker, there is floppy iris, and the plasma half-life 6 to 9 hours, better tolerated alpha 1 blocker for BHP compared to prazosin. Silodosin. Silodosin is like that of basic tamsulosin. It is a selective alpha 1A blocker, relieves symptoms of BHP. Postural hypotension is low, but failure of ejaculation is frequent here. Bioavailability 30%, metabolized by glucuronidation, excreted in urine and in feces. Uses of alpha blockers, number one, pheochromocytoma, and then hypertension, benign hyperplasia of prostate, peripheral vascular disease, and then papaverine, phentolamine induced penile erection in a patient of impotence. Pheochromocytoma, basically it is a tumor in the adrenal medullary cells causing excessive release of catecholamine. Effect is persistent or intermittent hypertension. Now, how is it diagnosed? By estimation of urinary catecholamine metabolites, VMA or normetanephrines. In addition, there is a pharmacological test called phentolamine test. Why phentolamine is used? Because it's short acting. The effect is short. Phentolamine 5 mg is injected IV over 1 hour in a patient of recumbent position. Now, there is a fall in BP more than 35 systolic and or more than 25 diastolic. That is indicative of pheochromocytoma, not diagnostic false positive and false negative result may occur. Diagnostic is estimation of urinary catecholamine metabolites. Treatment, surgical removal is the best treatment, but in case of inoperable or malignant pheochromocytoma, phenoxybenzamine can be a choice. Alternatively, prazosin. And again, in patients of surgical removal of tumor, it is desirable to give phenoxybenzamine preoperatively for 1 to 2 weeks and infuse it IV during surgery. Rationale behind peri and intra and post-operative use of alpha blocker can use kora hoy in a patient of pheochromocytoma. Number 1, due to excess circulating catecholamines in a patient of pheochromocytoma, what happens? Blood volume is low. We all know that because of the catecholamine, they shift of blood or fluid from vascular to the extravascular compartment. So when the surgical treatment is taken up, what happens? The blood volume may decrease drastically. So treatment with alpha blocker normalizes blood volume and distribution of body water. Number 1. Number 2, during the handling of the tumor during surgery, the excess catecholamine may pour up in the blood and that can cause sudden hypertensive crisis. So this is prevented by phenoxybenzamine given pre and intraoperatively. Removal of the tumor is often attended by a marked fall in BP and that can be blocked by use of alpha blocker. Hypertension. Alpha blockers other than those selective for alpha 1 have been a failure in the management of essential hypertension because vasodilation is compensated by cardiac stimulation. We know that alpha blockers can cause and has got anti-hypertensive effect, but due to the beta 1 action, due to the cardiac stimulation, that can be minimized. Moreover, postural hypotension, impotence, nasal blockade and other side effects are unacceptable with the use of non-selective alpha blockers. However, phentolamine, phenoxybenzamine are of great value in controlling hypertension with clonidine withdrawal and in cheese reaction. Benign hyperplasia of prostate, what happens here? There is a hypertrophy of prostatic muscles. These patients have got two components. One is static component because of the hypertrophy of the prostate size is increased, and number 2, dynamic component where the urinary flow is obstructed because of increase in tone of the smooth muscle in the urothelial tissue. Now alpha blockers, they basically improve the dynamic component. Two classes of drugs are used in benign hyperplasia of prostate. Number 1 is alpha blocker, prazosin like, and number 2 is 5-alpha reductase inhibitors, finasteride, dutasteride. They basically decrease the size of prostate. Now what happens? Due to the alpha 1 adrenoreceptor blockade, there is more complete emptying of urinary bladder in many patients of benign hyperplasia of prostate. Effect is quick in 1 to 2 weeks and lasts only till the drug is continued. Drug stop করার পর symptoms আবার আরম্ভ হয়ে যায়. Therefore, faster relief, greater symptomatic relief. Now, voiding symptoms are relieved better than irritative symptoms like urgency, frequency, nocturia. The alpha 1 blocker do not affect the prostatic size only till the drug is given. Benefit may decline after few years. Terazosin, doxazosin, alfuzosin and tamsulosin are the preferred drug. Extra advantage with terazosin and doxazosin, they have got prostatic apoptosis promoting activity, and tamsulosin appears to cause fewer vascular side effects. Postural hypotension is low. Now coming to beta adrenergic blocking drugs, they inhibit adrenergic responses mediated through beta receptor. We all know beta receptors are 3 types: beta 1, beta 2 and beta 3. Beta 3 is present in adipose tissue of less relevance. We more deal with beta 1 and beta 2. Beta 1 receptor কোথায় আছে? Heart এর আছে. They have got positive chronotropic inotropic effect, তাই তো? And beta 2 receptor কোথায় আছে? lungs এ আছে. They cause bronchodilation, তাই তো? আর কোথায় আছে বিটা 2? হ্যাঁ, vascular smooth muscle, they cause vasodilatation. All beta blockers are competitive antagonists. Now beta blockers দু টাইপের আছে, non selective and selective. So non selective is the propranolol. It is blocking beta 1 and beta 2 receptors with weak activity on beta 3 subtype. Additionally, propranolol is a prototype drug, prototype beta blocker. Now additionally they have got inverse agonist activity, reduces resting heart rate as well. Now some beta blockers like metoprolol, atenolol, they preferentially block beta 1 receptor, not beta 2. So they are cardioselective beta 1 blocker, they are said. While few others have got additional activity on the alpha 1 receptor, or they can have additional vasodilating property like nebivolol. Now this is a classification of beta adrenergic blocking drugs: non-selective, without intrinsic sympathomimetic activity, that include propranolol, sotalol, timolol; with intrinsic sympathomimetic activity, pindolol; with alpha blocking property, labetalol, carvedilol; and then cardioselective beta 1 blocker, metoprolol, atenolol, bisoprolol, esmolol, celiprolol, nebivolol. Is one classification according to the receptor inhibition. Now there is another classification: first generation, second generation, third generation. First generation mane ki they are older drugs, non-selective beta blockers like propranolol, timolol, sotalol, pindolol. Then the next is cardioselective beta blockers, cardioselective beta 1 blocker, that is second generation: metoprolol, atenolol, bisoprolol, esmolol. And the third is beta action along with additional action on the alpha receptor or having vasodilatory property, that in the third generation: labetalol, carvedilol, celiprolol, nebivolol. Now pharmacological action: cardiovascular system, respiratory tract, CNS, local anesthetic, metabolic, skeletal muscle, eye and uterus. Now heart. Propranolol, because it is blocking beta 1 receptor, they decrease heart rate, force of contraction. Now what happens due to that? Cardiac output is decreased. Now it prolongs systole also. How? By retarding conduction. Those they have got additional effect on the electrophysiological system. They prolong the systole. The effect on a normal resting subject are mild. Why? Because in a normal resting subject, parasympathetic tone is higher than the sympathetic tone, but it becomes prominent under sympathetic overactivity, like in case of exercise, in emotion. Ventricular dimensions are decreased in normal subject, but dilatation can occur in those with reduced cardiac reserve, like in case of congestive heart failure. So these drugs should be cautiously used in congestive heart failure patient. Cardiac work and oxygen consumption are reduced, then total coronary flow is reduced. Why? Because beta 2 receptors are present in the coronary vascular bed, that is causing vasodilatation. Now because of beta blocking action, there is coronary vasoconstriction, so coronary flow is reduced. But this is largely restricted to the subepicardial region. In a patient of ischemic heart disease, what happens? The ischemic zone is more in the subendocardial zone. Now what happens? Beta blockers they preferentially decrease the coronary blood flow in the subepicardial region compared to the subendocardial region. So what happens in ischemic heart disease patient? There is increase in the blood flow in the subendocardial region. So there is improvement of oxygen supply and demand status. So in a patient of ischemic heart disease, they improve the exercise tolerance. Propranolol abbreviates refractory period of the myocardial fibers and decreases automaticity. Rate of diastolic depolarization is decreased. Diastolic depolarization মানে cardiac action potential পড়েছে ফিজিওলজিতে কি ফেজ হয়? ফেজ 0, 1, 2, 3, 4, তাই তো? ফেজ 4 এর পর যখন This is phase 4, right? So, now in case of cardiac tissue, which are basically pacemakers, they have got they spontaneously the membrane potential reaches to the threshold and then fires, and this slope is called basically diastolic depolarization. Now what happens, beta blockers reduces the rate of diastolic depolarization in the basically cardiac myofibers. So AV conduction is slowed. At high doses, direct depressant and membrane stabilizing action is exerted, but contributes little to the antiarrhythmic effect. Propranolol blocks cardiac stimulant action of adrenergic drugs, but not of methylxanthines or glucagon. Now, reversal of vasomotor reversal of Dale. Earlier, what we read? What is vasomotor reversal of Dale? Vasomotor reversal of Dale. Normally, adrenaline show pressure response. They injected intravenously. They cause a rise in blood pressure. Now, before giving adrenaline, if we give alpha blocker prior, what will happen? Due to alpha blocking, when adrenaline is injected, there will be fall in BP instead of rise because of beta 2 action. So, this is called vasomotor reversal of Dale. Now, what is re-reversal of vasomotor reversal of Dale? Now, instead of alpha blocker, if we use beta blocker, then beta 2 mediated vasodilatation will not occur. So, the rise in BP will be increased and there will be no fall in BP, and that is basically re-reversal of vasomotor reversal of Dale. Now, no direct effect on the blood vessels. On prolonged administration, blood pressure gradually falls in hypertensive subject. So, they have got anti-hypertensive action. Now, how does it occur? Total peripheral resistance is increased initially. Why? Because we all know beta 2 causes vasodilatation. Now, because of beta 2 blockade, there is vasoconstriction that is causing increase in total peripheral resistance. And again, beta blockers, they decrease cardiac output. So, on chronic administration, due to persistently reduced cardiac output, there is increase in TPR, total peripheral resistance. So, ultimately, on prolonged administration, there is fall in both systolic and diastolic blood pressure. Systolic blood pressure is guided by cardiac output, while diastolic blood pressure is guided by peripheral resistance. So, on prolonged administration, beta blockers causes both fall in systolic and diastolic blood pressure. This is considered to be the most likely explanation of anti-hypertensive action. পরীক্ষাতে শর্ট নোট আসতে পারে বেটা ব্লকার্স অ্যাজ অ্যান্টি হাইপারটেনসিভ এজেন্ট, সেখানে কিন্তু তোমাকে লিখতে হবে। আদার মেকানিজমস, reduced noradrenaline release from the sympathetic terminus, decreased renin release from the kidney, beta 1 mediated, and central action reducing sympathetic outflow. These are the other mechanisms of anti-hypertensive effect of beta blockers. Respiratory tract. Respiratory tract কোন রিসেপ্টর থাকে? কোন বিটা রিসেপ্টর থাকে? beta 2, that cause bronchodilation. Now, because of beta blockers, bronchoconstriction can occur, that can cause exacerbate COPD and asthma. But this effect is not seen in normal subject. Why? Because parasympathetic tone is higher than sympathetic tone. But in patients of COPD and asthma, if they are given beta blocker, into exacerbation or life-threatening attack can occur. Central nervous system, no overt central effect is seen. However, subtle behavioral change, forgetfulness, increased dreaming, nightmares can be seen. This suppresses anxiety, and hence beta blockers are also used as anti-anxiety drugs. They suppress anxiety in short-term stressful situations, but this action is peripheral, not central. Local anesthetic, beta blockers have got additional membrane stabilizing action because of sodium channel blocking property, and is a potent local anesthetic drug, but not used clinically. Why? Because of irritant action. And although beta blocker propranolol, they can decrease intraocular pressure, they are not used as a topical preparation in the eye because of ocular irritation and corneal anesthesia. Now coming to the metabolic effect, propranolol, they blocks adrenergically mediated lipolysis. So what will happen? The free fatty acid level will increase, the triglyceride level will increase, the HDL level will go down. Glycogenolysis in heart, skeletal muscles and liver will be attenuated. So what will happen? Recovery from insulin hypoglycemia will be delayed. So beta blockers should be cautiously used in diabetics, or better to be avoided if not needed. Though there is no effect on normal blood sugar level, prolonged propranolol therapy may impair carbohydrate intolerance by decreasing insulin release from the pancreas. They inhibit adrenergically provoked tremor. They are useful in essential tremor patients. The action is beta 2 mediated. This is a peripheral action exerted directly on muscle fibers through beta 2 receptor. Propranolol also tend to reduce exercise capacity. Decrease করে দেয় কেন? Because by attenuating beta 2 mediated increase in blood flow to the exercising muscles. যে মাসলগুলো এক্সারসাইজ করছে সেখানে যদি vasodilation টা ব্লক হয়ে যায়, vasoconstriction হয়, blood supply টা কমে যাবে, as well as by limiting glycogenolysis and lipolysis in the working muscle. So the basically nutrient availability in the exercising muscles will be decreased. Coming to the eye, action on the eye, intraocular tension, they decrease, so they are useful in glaucoma patients. How they does it? By reducing secretion of the aqueous humor. No effect on the pupil size or accommodation. Uterus, normal uterine activity is not significantly affected. In response to isoprenaline and selective beta 2 agonists, there is uterine relaxation. Pharmacokinetics, well absorbed, bioavailability is low due to high first pass metabolism in liver. Propranolol kintu liver e kintu is one of the drug having high first pass metabolism that occurs in liver. Overall is to parenteral ratio 40:1. Inter-individual variation can be seen in the first pass metabolism. Propranolol is lipophilic, they penetrate into the brain easily. Metabolism is dependent on the hepatic blood flow. It has been seen that on chronic administration of the propranolol, hepatic blood flow is decreased. As a result, on chronic administration, the bioavailability of the propranolol increases by about 30%. Bioavailability is higher with meals, so it should be taken with meal. Metabolism of propranolol is saturable. So as we decrease this dose of the propranolol, lesser will be the metabolism and the bioavailability increases further. These are excreted in urine as glucuronides. More than 90% of the propranolol are plasma protein bound. Interaction, when given with verapamil or digitalis, what happens? There can be severe AV conduction depression or sinus node depression. Severe bradycardia may be seen. The propranolol in diabetics, why it should not be preferred? The reasons are: number one, they delay the recovery of hypoglycemia. Why? Because they are blocking the glycogenolysis in the liver, skeletal muscles and others. Number two, warning signs of hypoglycemia. একটা পেশেন্ট হাইপোগ্লাইসেমিয়া হলে কিভাবে বুঝতে পারি আমরা? The patient may have tremor, may have sweating, may have palpitation. These are adrenergically mediated. Now, when we are giving beta blockers, the warning signs of hypoglycemia are decreased. So, if a patient is having hypoglycemia, we will not be able to understand, and that can precipitate dangerous hypoglycemia. So, warning signs of hypoglycemia mediated through sympathetic stimulation are suppressed. Phenylephrine, ephedrine and other alpha agonists present in cold remedies can cause marked rise in blood pressure because the patient is already on beta blockers, so vasodilatation is not occurring. Indomethacin and other NSAIDs, they attenuates the antihypertensive effect of beta blocker. They also retard lidocaine metabolism. Adverse effect, they accentuate myocardial insufficiency and can precipitate congestive heart failure and edema. So, it should be cautiously used in patients of congestive heart failure. It should not be used, it is contraindicated in decompensated congestive heart failure because it can exacerbate it, but they are indicated in compensated heart failure. It should be started with a lower dose and gradually build up to the maximum tolerated dose. Bradycardia is the most common side effect. Resting heart rate may be reduced to 60 per minute or lesser. Patients of sick sinus syndrome are more prone to it. Propranolol worsens COPD and asthma. They exacerbate basically variant angina. What is variant angina? In a patient of variant angina, there is intermittent vasospasticity, coronary vasospasm. Now, this can be increased by propranolol because they are blocking beta 2 receptor mediated vasodilatation. Propranolol is better avoided in diabetics, already discussed. Plasma lipid profile is altered on long-term use, already discussed. Triglyceride may rise, HDL may go down. Withdrawal of propranolol after chronic use should be gradual. Why? Because on chronic administration of a beta blocker, there is upregulation of the beta blockers. Now, what happens if we suddenly withdraw the drug? There will be sudden spurt in the sympathetic overactivity, and that can cause basically rebound hypertension, worsening of angina, and even sudden cardiac death. Propranolol is contraindicated in partial and complete heart block. Tiredness and reduced exercising capacity may be felt, already discussed. Cold hands and feet may be noticed during winter due to blockade of vasodilator beta 2 receptors. Peripheral vascular disease can be worsened. Now, side effects others are GIT upset, lack of drive, nightmares and forgetfulness. Mental depression can be seen and sexual distress can be seen. Other beta blockers can be divided as per cardioselectivity, partial agonistic activity, membrane stabilizing activity and low lipid solubility. Coming to cardioselectivity, beta 1 blocker. Cardioselectivity means they are blocking maximally beta 1 receptor. Examples are metoprolol, atenolol, bisoprolol, nebivolol. These are most potent blocking cardiac beta 1 than bronchial beta 2. So, what the advantage? Lower propensity of bronchoconstriction. So, if at all beta blocker has to be used in COPD and asthma patients, cardioselective beta 1 blockers are preferred. Less interference with carbohydrate metabolism and less inhibition of glycogenolysis. So, safer in diabetics. Lower incidence of cold hand and feet. Why? Because beta 2 action nahi. So, vasodilatory beta 2 effect block hobe na. Lesser chance of precipitating Raynaud's phenomenon. No or less deleterious effect on the lipid profile. Ineffective in suppressing essential tremor because it is beta 2 receptor mediated. Less liable to impair exercise capacity. Now, coming to partial agonistic or having intrinsic sympathomimetic activity. Now, these drugs themselves activate beta 1 and or beta 2 receptors submaximally. Benefit: bradycardia and depression of contractility at rest are not prominent because they have got additional intrinsic sympathomimetic activity. They are also having agonistic activity on either beta 1 or beta 2 receptor additional. So, bradycardia and depression of contractility not prominent. Withdrawal, sudden withdrawal যেগুলো rebound hypertension angina করছিল কিন্তু এই ড্রাগগুলো কিন্তু খুব কম করে. Withdrawal is less likely to exacerbate hypertension or angina. Plasma lipid profile is less worsened, not effective in migraine prophylaxis. Migraine সম্বন্ধে serotonergic drugs সম্বন্ধে পড়া হবে. So, migraine prophylaxis one of the drugs used is beta blockers. So, these drugs are not effective, not suitable for secondary prophylaxis of myocardial infarction. Membrane stabilizing activity, that is the sodium channel blocking property, So includes propranolol, oxprenolol, acebutolol. So they have got additional anti-arrhythmic actions, but that appears to be less significant clinically. They cannot be used topically for glaucoma because they anesthetize cornea and they cause basically corneal irritation. Low lipid solubility, atenolol, celiprolol, bisoprolol, sotalol. Now because of low lipid solubility, their oral absorption is impaired. So bioavailability is lower. They do not undergo first pass metabolism. Longer acting because of high lipid solubility tend to be effective in a narrow dose range. Now coming to individual drugs, sotalol. Sotalol is a non-selective beta blocker having low lipid solubility. Now in addition, these drugs have caused got potassium channel blocking property. So they are class 3 anti-arrhythmic drugs. যখন anti-arrhythmic drugs পড়ানো হবে সেই ড্রাগগুলো বিভিন্ন ক্লাসে থাকে, ক্লাস 1, ক্লাস 2, ক্লাস 3, ক্লাস 4. The class 3 drugs, they blocks rectifier potassium channels, delayed rectifier potassium channels. Timolol, they are used as anti-glaucoma drugs because of absence of local anesthetic activity and good lipid solubility. Pindolol, they have got additional intrinsic sympathomimetic activity, so less marked bradycardia, chances of rebound hypertension is low, plasma lipid profile is less %. Metoprolol, metoprolol is a prototype cardioselective beta 1 blocker. So additionally they have got inverse agonistic activity on beta 1 receptors, less likely to worsen asthma, preferred in diabetics, and the basically peripheral vascular disease are less %. First mass metabolism is less marked, although 90% of the drug is hydroxylated by CYP2D6 enzyme. Now this enzyme shows genetic polymorphism, and there are two types of population. One are extensive metabolizers and poor metabolizers of metoprolol. Hypertension, angina and congestive heart failure, it is used. Metoprolol is an active enantiomer and used in half the dose. Atenolol is again a cardioselective beta 1 blocker, low lipid solubility, incompletely absorbed, first pass metabolism is low. Side effect to CNS are less likely because of low lipid solubility. Lipid profile is less %. Used in hypertension, angina and in patients of congestive heart failure. Acebutolol, they have got significant partial agonistic and membrane stabilizing property. Now this drug is safer in resting heart rate, is not decreased as much. The active metabolite diacetyl is longer acting, 8 to 12 hours. Bisoprolol is the cardioselective beta 1 blocker suitable for angina, hypertension and congestive heart failure. Esmolol is a ultra short acting beta blocker. Ultra short acting মানে hypertension use করা যাবে না, কোথায় use করা যেতে পারে? Now is the ultra short acting beta blocker with partial agonistic or membrane stabilizing action. Why is ultra short acting? Because it is metabolized by the enzyme esterases in blood. So the plasma half life is less than 10 minutes and the action disappears 15 to 20 minutes after terminating IV infusion. So in case of dangerous arrhythmias where beta blockers can act, esmolol is preferred because of their short action. They are used to terminate supraventricular tachycardia, episodes of atrial flutter and fibrillation, arrhythmia during anesthesia. Nebivolol, these are the third generation beta blocker. Additionally, they have got nitric oxide generating property. So they cause vasodilatation. Absence of deleterious effect on the plasma lipid or carbohydrate metabolism. Increase insulin sensitivity event. Then the hypotensive response has a rapid onset, used in hypertension and congestive heart failure. Celiprolol, they have got additional beta 2 agonistic action, so they are safer in asthmatic patients. And additionally, due to production of nitric oxide, they have got additional vasodilatory property like that of nebivolol.